Okay, well, it's John Bear here. I'm going to introduce Dr. Vivian Huang, who is an assistant professor and clinician investigator in the Division of Gastroenterology at Mount Sinai Hospital and the University of Toronto. She is also an adjunct assistant professor in the Division of Gastroenterology at the University of Alberta. She completed medical school and internal medicine residency at Queen's University and gastroenterology fellowship at the University of Toronto, funded by the Alberta Innovates Health Solutions Clinician Research Fellowship. She obtained an advanced IBD clinical research fellowship and Masters of Science in Medicine at the University of Alberta, where she developed the Northern Alberta Preconception and Pregnancy in IBD Clinical Research Program and continues to direct clinical research. Over to you, Jamie.
At Mount Sinai Hospital in Toronto, she is establishing the Preconception and Pregnancy and IBD Clinical Research Program for Toronto and Ontario. Her primary clinical research interests include using multidisciplinary approaches and e-health strategies to incorporate P4, predictive, preventive, participatory, and personalized medicine to optimize maternal, fetal, and neonatal outcomes in IBD, and conducting translational studies investigating the impact of maternal IBD and therapies on the fetus and neonate. So Dr. Huang has helped me personally through my journey with IBD postpartum with my first child and through my second pregnancy postpartum with my second. I feel extremely grateful to call someone as established in her field, my GI, and someone who has a diagnosis of IBD herself. The trust I had in her was beyond compare. So I feel honored to pass things over to the very accomplished Dr. Vivian Huang, who has had such a positive impact on many of us navigating this disease. The stage is yours.
Thank you for those really kind introduction, John and Jamie, and to Brenda for connecting me to speak to you today. I hope the share screen works here. So I was asked to give an update about management of IBD. And coming, as Jamie mentioned, I do have IBD myself and have gone through being a patient, still am a patient, and being on the other side now as a clinician and a physician. I've realized over the years, some of the terminology that we might say in our clinics are probably a little bit over some people's heads and hard to help understand where your physician might be coming from and where you're coming from. So I hope this presentation might bring the circle of care a little bit tighter for everybody. So I wanted to review with you the advancements and the change in the way clinicians are approaching the management of IBD, and then just review the currently available medications, and just to share with you, as you're probably familiar with, the huge explosion in available medications for IBD over the last couple of years, and how your clinician might discuss with you and ask you questions about your life and your other comorbidities to try to figure out which might be the best medication or medication options for you. And then just a team approach and how important you are in your team. So I just wanted to go through that. So we're talking about Crohn's disease, which can affect anywhere from gum to bum, and ulcerative colitis, which by definition is limited to the colon. Unfortunately, even to date now, we don't know exactly why people get IBD. We do know from the research, and I think Dr. Lee is going to talk to you in a later session, but a lot of the research is advancing, and we do know there might be a little bit of genetic risk, but it's not 100% genetic disease. So what else could cause it? We know there are things to do with the environment, so diet, pollution, westernization, they call it, has been shown to increase the risk of inflammatory bowel disease. And the microbiome, so the gut bacteria, is important. And all of this together is triggering for some people immune response that continues and causes bowel disease. So we know that people with IBD can have complications, and I just illustrate a few of these. So Crohn's disease can, as I mentioned, is gum to bum disease. It can affect all layers of the bowel, and thus it can create strictures, so narrowing and tightenings of the bowel. And many of you may have suffered from these strictures. It can cause you the pain and bloating after eating, and may need surgery for it. And then the Crohn's, because it can affect all layers of the bowel, can poke holes and make fistulas, connections between bowel and other organs. And that sometimes we can help you with medications, but sometimes we'll need surgery for. And then Crohn's can also affect around the bum. So you can get fistulas around the bum and anus and abscesses, inflammatory skin tags, and complications down there. And again, we try to help with medications, but in some cases, you'll still need surgery involvement. Ulcerative colitis does not lead to these specific complications, but ulcerative colitis can also cause that kind of narrowing in the colon in the sense that over time, some people, their colons can, I call it like shrunken, like it can become like a tube or a pipe shape. And thus you get those symptoms of constipation or sometimes diarrhea. And that can be a sequelae of chronic inflammation. So as clinicians, we aim to help you feel better. We try to help you find the right medications to heal the inflamed parts of the bowel. And we try to do that as soon and as quickly as we can to try to prevent the ongoing bowel damage that can lead to these complications of strictures and fistulas and tubular colons. We also want to try to treat the inflammation as quickly as we can and get it under control to reduce the risks of cancer. So people who have long-standing inflammation in the colon, and in some cases the small bowel, you can increase the risk of cancer. And so that's why we are being a little bit more, I guess, aggressive in terms of recommending treatments earlier, even if people feel better. And I'll walk through that in the next session here, because what I want to explain to you is over the last couple of years, based on the research out there and understanding the progression of these inflammatory bowel diseases, we do know that treat to target approach, aiming for the deepest remission possible, can potentially reduce the risk or even prevent these complications from happening. And so what is this treat to target approach that many of us are now, well, that's the new recommendation, is that we aim for this deep remission. So we want to help people feel better. So symptomatic response and as quickly as possible. But not only that, we want you to stay feeling better. So symptomatic remission. And we are hoping to show that by normalization of the inflammatory biomarkers. So the easiest one is the blood test, the C-reactive protein or CRP. But then many of you will probably be asked to do stool sample tests for fecal calprotectin. And that's a biomarker for inflammation in the gut. And so we're trying to also make sure that that normalizes. And then ideally we'll do the colonoscopies, or depending on where your inflammation is, gastroscopies, other scopes to confirm that the lining of your bowel has healed. And then obviously we do want you to have a better quality of life and absence of disability, meaning we're hoping, if you're going to school or going to classes, taking care of family, we want you to be able to do that, get back to that. And on the right-hand side is the more newer targets that we are trying to aim is for Crohn's, because it can affect all layers of the bowel. Sometimes on the scope tests, everything looks good. But then we get an imaging test that might show that there's still inflammation in the walls of the bowel. And so sometimes we might adjust your therapy to try to get that inflammation under control. For ulcerative colitis, there's evidence that not only getting the lining healed, but actually on the microscopic level. So when we take the biopsies, we're trying to see if we can actually get that inflammation under control as well. And that's why the physicians will constantly be asking patients to do blood tests, stool sample tests, scopes, and imaging in a cycle, and optimizing the medications to try to see if we can get to that deep remission. And there is evidence. So this is a diagram that tries to show that progression of disease that happens for many people. This is a Crohn's disease diagram. So if you look at the bottom, it's trying to show you over time. We believe, just based on the research out there, that people do have symptoms. People have inflammation and potentially symptoms before your diagnosis. And for some people, that could be years. Some people, it could be weeks. But if that inflammation and diagnosis doesn't occur quickly, and that inflammation is allowed to progress, and then in some people it does cause that bowel damage or strictures and fistulas, and then might need surgery to treat that. So there is evidence based on the studies that have been done that treating ideally within 2 years of diagnosis can reduce those risks of complication and can reduce risk of needing surgery to treat the complication. So I kind of mentioned different things that the clinicians will ask you to do, like in terms of assessing your disease activity. Many of you who come to Mount Sinai, you know we are asking you these surveys, and that's just to help understand how symptoms are. So there's different scores for ulcerative colitis versus Crohn's disease. But the important thing to realize is symptoms do not always mean active disease. There's many things that can cause symptoms. If you have irritable bowel syndrome, that can also cause cramps and diarrhea or constipation, depending. If you may have heard out there now, there's a lot of food poisoning or rotavirus or norovirus. All those can cause symptoms, but that does not necessarily mean the IBD is active. On the other hand, you can have active disease without symptoms. You might be telling us, or your gastroenterologist, that, hey, I feel great. Like, what do you mean that I have inflammation? Well, that's because it doesn't always correlate. So that's why we do all those objective disease activities to actually see if there's inflammation happening. And it does make a difference because we wouldn't want to give you steroids if you have an infection. We wouldn't want to give you steroids or biologic if it's irritable bowel syndrome causing your symptoms. There's other angles of treatment for those. So the common blood tests you might be familiar with are CBC to check your complete blood count, to check if you have anemia that we need to treat, check for elevated white blood cells, which sometimes is a reflection of inflammation. And then the common C-reactive protein, the inflammation marker. But it's important to know that CRP can go up for non-IBD reasons. So if you have the infections or other inflammatory conditions, that can make your C-reactive protein go up. And then on the other hand, not everyone makes a CRP response. So sometimes your CRP might be normal. You're checking your life labs or Dynacare and it looks good. But again, you might be having inflammation based on other tests. And then we will often routinely check other things for nutrition assessment. So vitamin B12 and vitamin D are the most common ones. And also, if you have signs of anemia, we check your iron levels as well to see if you need iron. And just please feel free to stop along the way if anybody has questions or I'm talking too fast. And then, so the stool tests, which I know not everybody likes to do, but as I mentioned, there are a lot of infections out there. So we need to check if you're having diarrhea, that we need to check for those infections. Clostridium difficile or C. diff is very common in people who have IBD, people who have been in and out of the hospital or hospital settings. So we always need to check that. Culture sensitivity refers to the bacteria like Salmonella, Shigella, the food poisoning type of bacteria. And then ovum parasites, especially if you have been traveling down south to Mexico, or if you ate sushi, stuff like that, or camping, we definitely need to check that. And then I mentioned the fecal calprotectin earlier. Calprotectin is a protein found in white blood cells, and fecal calprotectin is a measure of that protein in your stool. So the thing is also to know, that's why your GI might ask you, do you take any like NSAIDs or aspirin or Advil? Sometimes that might cause a little bit of inflammation in the gut and make your fecal calprotectin go up. So they'll ask you some of those questions along those. And then, of course, we do look at the inside lining of your bowel, depending on where your symptoms are and where your disease is. It goes from colonoscopies, sigmoidoscopies, pouchoscopy, ileoscopy, and gastroscopy. And on the left is a picture of a healthy, normal colon, and on the right is an inflamed bowel from ulcerative colitis. And just a little note, I'm going to say, like, I know it's not easy to take the colon prep. I've done it many times myself, but it is super important to do your best, because you can imagine what it's like driving through a snowstorm. That's what it's like if someone didn't do their prep and there's a lot of stool in the colon. It's hard to see. It's we could miss like polyps or subtle areas of inflammation. And sometimes we may not be able to finish your colonoscopy and have to bring you back another day. So try your best. And then I mentioned the imaging tests. This is really important, especially for Crohn's disease, because as I mentioned, Crohn's disease can be through all layers of the walls of the bowel. And the most common tests that we do order are the CAT scans, and specifically the CT enterography, where the radiologist will have give an IV contrast, but also have you drink some contrast. And if you look on the left picture, that's what the CT is looking at. I don't have a pointer, sorry, but they're looking for thickened bowel wall. They're looking for any other complications, like the internal infections, the abscesses. They're looking for dilated bowel loops. And that's why they ask you to drink the contrast. And then MRI is very similar to CT scan. MRI, they do the MR enterographies as well. And we try not to do too many CTs in someone's life because if there is radiation, although Mount Sinai does offer the low dose radiation. But the problem with MRI, which if any of you have had it, is it takes about 45 minutes to do a proper small bowel MRI, and many people might not be able to tolerate that. So if you've had troubles with the MRI or claustrophobic or can't lie still for 45 minutes, then discuss it with your gastroenterologist. They may need to order different kinds of tests for you. However, if you have Crohn's disease around the bum, or there's a suspicion of perianal Crohn's disease, the best test for that is an MRI. And that one is usually shorter. You don't need to drink the contrast. But it does give the best image for the subtle fistula traps around the bum. And then the final imaging test that we will do is ultrasound. And that's the picture on the right, where the two little white arrows are showing a little bit of thickened bowel wall. And that one is important to also understand that it's a very special technique for the intestinal bowel ultrasound. So not all radiologists do them. And that's why when we order it, like there's only done on certain days at Mount Sinai, and only certain technicians or radiologists do them. There's a few gastroenterologists that are trying to learn that, so myself included, and Dr. Silverberg, Dr. Gallinger, Dr. Tandon, if any of you have those as your GIs. We're all taking the courses to learn how to do this. And Dr. Silverberg actually has a machine at his clinic, the Toronto Immune Digestive Health Institute, is where we do some of these bowel ultrasounds as well. And you don't need to drink any contrast. There's no intravenous contrast. And I found when I've done it in the clinic that it does help, because as the patient, we'll show you, like we'll actually show you, like this is what your bowel looks like. If we see like the dilated bowel wall, or sorry, dilated bowel loops, like above a stricture, for example, I think it helps when you actually see it to understand like your symptoms, and we can explain to you, perhaps in some cases why surgical intervention might be needed versus medications. Okay, so let's briefly go through all the medications available. So this huge table is all the currently Health Canada approved medications for IBD. And there's different categories. So there's the pill forms, and then there's biologics. I wanted to focus a little bit on the biologics and a little bit on advanced therapies, because that's really changed in the last couple of years. And so some people, you might have different options now, or talk to your GI like about the different medications. But briefly on the left, typically 5 aminosalicylates, so Asacol, Mesavant, Pentasa, Salofolk, and now there's newer ones, Misera and Octasa, are colonic medications. So they work typically well for ulcerative colitis, mild to moderate ulcerative colitis, and in some cases Crohn's colitis. And then there's another older medication, salazapyrine or sulfasalazine, which works really well. It just has an extra sulfa part. So if you're allergic to any sulfa antibiotics, you have to tell your GI so they don't prescribe this one to you. And the benefit of the addition of the sulfa part is it does help arthritis. So if you have like joint symptoms, then your GI might switch you from a 5-ASA to the sulfasalazine. In the past, when we didn't have access to biologics, people who failed 5-ASAs and needed steroids repeatedly would go to a thiopurine, so Imuran or azathioprine, and perenethal or 6-mercaptopurine. And some of you may still be on that, and it works quite well for many people, but there is now over time with the research that's been observed, increased risk for skin cancers and lymphoma. So I don't prescribe it too much anymore. And if someone flares while they're on it, we start to move on to the more targeted, safer biologics and advanced therapies. However, you might still be asked to or recommended to take a thiopurine for short term if you're starting certain biologics because it can reduce the risk of you having a reaction or developing antibodies against the biologic. And then methotrexate is similar in that category of the immunomodulators. We still have some people who are doing really well on methotrexate by itself. Just have to monitor your liver tests and blood counts over time, but there's no significant flag for lymphoma reported. And methotrexate works well if you have the arthritis component as well. And then you're familiar with steroids. I'm sure everybody's been on a course of steroids of some sort, but prednisone, as you know, is quite systemic. So there are a lot of side effects that people can get, like anxiety, depression, sleep disturbances. You can get skin, like acne and other skin side effects. You can get risk of bone loss. There's risk of diabetes. There's risk of blood pressure and eye problems, which is why, we'll use it if you're very sick and flaring, but we're always trying to get people off steroids. The more newer steroids, budesonide CR or controlled release refers to Entocort. So Entocort was designed to release in the ileum. You still absorb it systemically, but your body will metabolize 90% of it, so only 10% is in systemic, and then the rest is targeted to your ileum. So very commonly, if you have Crohn's disease of the ileum, we will use Entocort. The newer one, budesonide MMX, is Cortiment, and that one is designed to release directly in your colon, so like pretty much no prednisone type of side effects for that one. However, over time, you're still going to absorb some, so we prefer not to have people on it long term. And then on the right-hand side, and I'll go through each one to try to explain a little bit so that you understand the mechanisms and how they're given. But those are all the different classes of biologics and advanced therapies that are available. And this is the history. So those first ones I've told you about were all that was basically available before 2010. And then between 2010 to up to 2016, there was the common one that you may have heard of or been on, Remicade, Humira, and Simponi, so the anti-TNFs. And then there was the newer ones, the anti-integrin, anti-IL-12/23s from 2016 to 2018. And then there were the biosimilars, where other brand companies made their version of the Remicade and Humira molecules. And then because of the cost issues and different province coverage and insurance, many of you may have had to go biosimilar switch in the last couple of years. And then there was a newer, what we call the small molecules, so the pills, the Xeljanz and Zeposia were the brand names. And those all came out 2019, 2022. And then 2022, 2024, there were newer biologics. And I can't believe it's already been 2 years, but the Skyrizi and Omvo, and there will be newer ones this year, we heard, based on the clinical trials successes. And then more of those small molecule pills. And then this year, there's more biosimilars. So don't worry if you don't remember any of these names or stuff, but just if you're encountering troubles with your current medications, there's still hope because every year there's newer treatments coming out. So just better understand, I think it's important that people try, like, if I can try to explain some of the science behind these. So people always get worried about biologics and how they work, and you know, some people actually prefer to stay on prednisone, even though prednisone has a lot of side effects. What I can tell you is the biologics, each newer biologic, the scientists have made it more targeted, more safer, like because they're not as systemic anymore. And that's, I think it's important for people to understand that. So I wanted to go through these a little bit in detail for you. So when you hear like if your clinician says, like these anti-TNF biologics, the infliximab, adalimumab, or golimumab ones, they work by binding this inflammatory protein called TNF protein. That's a cytokine, so it's a protein floating around in your body that triggers inflammation. And these biologics block it. So they stop that pathway or minimize that pathway from happening. The one that came after those ones was the anti-integrin biologics. There's only one on the market now, it's Entyvio. And the way that one works is completely different. This one blocks the binding of white blood cells to receptors on the gut lining. So these and in order, like the white blood cells bind to this MAdCAM1 receptor and then crosses into the gut mucosa and cause inflammation. And so it doesn't block all of it. So you don't need to be worried that this medication is going to completely wipe out your gut immune system. When they did like the initial research before like the clinical trials, they showed that it only blocks about 3 to 5% of the white blood cells. And that might explain why Entyvio may take a little bit longer to work for people, because the white blood cells that are already in your gut they have to just die off and like disappear. But the Entyvio is trying to block new white blood cells from getting to the gut. So it does take a little bit of time for it to kick in. And that's important to understand because we want you to feel better quickly and you want to feel better quickly, but sometimes the medications take a few months before they fully work. So not to give up on the medication too quickly. And then the newer ones, anti-IL-12/23, so that's the Stelara one, and they're biosimilars to Stelara. And then the anti-IL-12/23 work in a totally different pathway again. So instead of blocking cytokines, so the IL-12 and the 23 circles are the cytokines, and those cytokines bind to these receptors on the cell, and then that triggers a inflammatory pathway. So these medications don't actually neutralize those they don't neutralize those cytokines. They actually block the downstream pathway and interfere with how those inflammatory proteins trigger inflammation. So the first one that came out was the Stelara, and now there's a few biosimilars to Stelara, and they block both of these pathways. So the scientists, when they were studying this, found that it might actually be this one particular pathway, the IL-23 pathway, that might be what's causing the inflammation in IBD. And so they designed more targeted biologics, risankizumab and mirikizumab, which are on the market now and approved for Crohn's and ulcerative colitis. And they seem potentially to work better. And I say potentially because it's a little bit hard to explain, but the clinical trials designs and how they didn't all compare directly like to Stelara, et cetera. So some of it has to be assessed on post-marketing research. But we do know, for example, in other disease conditions that use the anti-IL-23 pathway, so like psoriasis, they have found that this pathway works like much, much better than the anti-TNF pathway or the IL-12/23 pathway. So they've all gone to this particular IL-23 pathway for their patients with psoriasis. And so anybody who has Crohn's, for example, and psoriasis, most likely would recommend the Skyrizi medication at this point for that reason. And these, as I mentioned, they are proteins antibodies that target these different pathways. And that's why it's really important to understand the importance of you, if you're on this medication, to take it on schedule. So each one of these biologics have induction period and a maintenance period. So induction is the initial doses to try to get the medication in your system. And then maintenance is either every 2 weeks, every 4 weeks, every 8 weeks. And then some people have to go even shorter intervals to try to get the levels higher. And the reason it's important to stay on schedule and not miss doses is because your body can actually build antibodies to these antibody medications. So if you think about, for example, I guess the most common illustration is vaccinations. So when you get a vaccination, usually you have to get a few doses. And so if you are on a biological protein that's a medication, and you are sometimes taking it, sometimes not taking it, your body can actually view that you're being vaccinated to that medication, and you develop antibodies or resistance to it. So it's really important to stay on the schedule. So now that I've told you about all these different biologics and everything newer that's come on available for people with IBD, how do we help you find the right medication? So there's these 5 common things that I think might help you understand a bit. So it's your diagnosis, so whether you have Crohn's or ulcerative colitis. It's how your IBD behaves, whether you have those fistulas or perianal disease, comorbidities, your prior biologic treatment, and your family planning plans. So I'll go through those as well. So IBD diagnosis can affect which treatment and access. And part of that is because based on whichever medication it is, the level of evidence from the clinical trials. In some cases, there's certain medications that never got approved for certain indication because the clinical trials didn't work. Like it wasn't giving enough benefit that Health Canada or the FDA would approve it. And then the other thing is Canada may have different access to medications compared to United States or other countries, because every country has their own authority that looks at all the evidence and makes a decision about what to allow or approve in Canada. And then there's some nuances about insurance coverage or access. And there's different ways to get access to these very expensive medications, which is government insurance, so Trillium or ODSP and ODB, which are usually through limited use or exceptional access, and private insurance. And then there's compassionate access by some of the patient support programs. And then in some cases, if you need an off-label, for example, if you've been through many different medications and, in other, let's say as a GI, we know that there is some clinical trials evidence or other countries already have access to certain medication, then we will write to the government, we'll submit forms for your insurance to try to see if we can get access to that. And the reason I bring this up is very important because we try our best to help and get access for you to have access to medications, but sometimes it's you that needs also to help. So I'll give you an example. And I've been through this because I moved provinces and stuff like for my training, and I also had to learn like how exactly do myself as a patient and how do my patients get access to medications and covered. So in Ontario, if you are on the government insurance and you're on the Trillium plan, there's a deductible up to 4% of income. And unfortunately, not all patient support programs will be able to help pay 100% of the medications. And so many of them, they'll help support bridging, like they'll give some free doses along the way, but they ask people to apply to the government insurance and, get what is your deductible, and then the patient support program helps you out with some of that deductible and stuff. But it does rely on that communication back and forth with the patient support program and then with your gastroenterologist to make sure that we can get you access to the medications that you need. And then the way your IBD behaves can guide therapy as well. So there is more evidence for certain biologics and advanced therapies for certain types of IBD. For example, for perianal Crohn's disease, the strongest evidence out there is for the anti-TNF medications. So typically it's infliximab, and then strong evidence for adalimumab. So generally, if you're never been on a biologic before and you have perianal disease, those are the ones usually that we'll recommend first. And then there's growing post-clinical trials, real-world evidence, where if people failed these anti-TNF medications and needed to go on other biologics, we are trying to observe, like, will those help with the people with perianal disease as well? And then I mentioned your comorbidity, so other medical conditions that you may have may also be a guidance of which is the best medication for you. So if you have certain types of arthritis like ankylosing spondylitis, typically we'd recommend the anti-tumor necrosis factor agents, or even the JAK inhibitor one, the pill one, upadacitinib. And that's because there is evidence in the clinical trials and in the like real world data that these types of medications work for that type of arthritis. And then if you have psoriasis, I already mentioned, like they've shown in their studies that the anti-IL-23 agents work very well to clear up the psoriasis. So if you have IBD and psoriasis, we'll now usually recommend that class of medication. And if you're unfortunate to have cancer of some sort, depending which cancer it is, but most of the time, we try to get you on a gut-specific medications, especially if you need to take immunosuppressive chemotherapy. So it's really important to update your GI if you get diagnosed with any comorbidities. And then the other thing we look at, so if you have been on a biologic before, what's the second and third one and fourth one, and we don't have all the answers. People are trying to study that and figure out like what's the sequence of biologics. But the common things that we will look at and ask and look through your history, and if you're referred from another GI, look through what they've given us, is did that biologic that you've been on before ever work? So did it work and then it stopped working? In that case, like, did you get a dose escalation or frequency increase? Did you develop antibodies to that biologic and that's why it stopped working? And which was that first biologic? And then putting all that together, we'll try our best to give you the recommendations of the second options and third options. And then many of you would ask about diet therapy. And I would say right now, there's no one size fits all for diet either. However, general recommendations now is the Mediterranean diet. There is like evidence out there that that approach would be anti-inflammatory in nature. So basically it's like less reduced red meats, so staying more with chicken or fish. And then the like omega-3 fatty acids rather than like the saturated ones. So basically staying away from like fast food type stuff. And then fresh fruits and vegetables, if you can tolerate them. There are some studies that pointing towards, like for ulcerative colitis, that this approach of decreasing red and processed meats may actually reduce flares. However, a diet can be very individual for different people. So generally we would recommend you see a nutritionist or dietitian. Many people would be asking, oh, I have IBD, like, do I have to stay away from vegetables? No, you don't have to stay away from all vegetables. Again, it depends on your individual situation. So what this is trying to show you, for example, if you do have the strictures or the narrowings because of your inflammation and scarring and stuff, then yes, like usually we would recommend that you avoid high fiber or insoluble, undigestible type of fiber. And what do we mean by that? That's like this apple skins, broccoli, lettuce, corn, and stay more with soluble fibers or soluble type of vegetables. So potatoes, if you are going to have carrots, and you peel them and make sure they're well cooked, and in some cases you mash them and stuff, and then you'll be okay. There is some more research in the last couple of years that are showing tailored. So let me back up a step. Many of you may have heard of specific carbohydrate diet, and that's very restrictive and really hard to follow. So some researchers have looked into what's called the Crohn's disease exclusion diet, and that one is not as restricted, and it's a little bit modified in terms of some liquid and basic type of supplements, and then slow reintroduction of regular foods. And that has some evidence out there to benefit people with Crohn's. And part of that is learning from, I guess, more the pediatric, because pediatric IBD specialists have always used nutritional therapy for pediatrics, but it never really seems to work too well for adults. And part of that was thought because when you're a kid and a teenager, your immune system and your gut microbiota is kind of still developing, and so probably there's still a chance to try to modify it or help it. But nevertheless, like if you are interested in any of these, then talk to your GI, get a referral to dietitian, because these can be somewhat restrictive, and you have to make sure that it's under guidance. And then there's other situations where there will be very specific diet supplement through IV or parental nutrition or total parental nutrition. And that's typically if you have complications from your Crohn's, for example, where maybe you have a really tight stricture and eventually will need surgery resection. So pre-op, they want you to get your nutrition back and gain weight and be healthy for the surgery. So you might end up having to be a restricted diet with enteral nutrition or through the IV, the TPN. If you have that abscess, so I mentioned like Crohn's can poke holes and make those fistulas, but you can also make internal abscess. Again, we don't want a lot of food going inside your gut and a lot of secretions feeding that abscess and fistula. So then again, we'll back down to IV nutritions. And then for certain people who maybe you've had a lot of surgeries or very short bowel, you might need to have parental nutrition and supplementation along the way. And there are other research, which you've probably heard of for years, and again, it's still research. FMT, so fecal microbial transplant, that's where you get either enema or pills to give you what's considered a healthy stool from either a donor or artificially made. The problem is, okay, so it does work for C. diff. So people who've had recurrent C. difficile infections, the FMT is approved now as a treatment. But the research for Crohn's and ulcerative colitis, unfortunately, has been up and down. So some studies showed it worked, other studies showed it didn't work. And again, it's probably because inflammatory bowel disease is so complex, like there's so many things involved. The immune system, microbiota, the diet that's feeding it and stuff, that it's not one size fits all. And that's probably why it hasn't really been 100% successful. And then there's prebiotics, probiotics, and symbiotics. And there is evidence that those should help as well. So prebiotics are things that feed the bacteria. Probiotics is like giving you the healthy bacteria through not the stool transplant, but just probiotic like yogurts or powders that you take. And symbiotics are combinations of those two. And again, they help for some people and not help for others. And that's probably, again, because of the complexity of the whole interaction with microbiome and immune system. What I tell my patients is if you want to try it, it's okay to try the probiotic and prebiotics, but just because one doesn't work doesn't mean that another one might not work, because each one has different combinations of different bacteria in it. And it might just be the timing, like what's happening in your inflammation at that time. And then the new exciting thing that's happening in clinical trials now are medications that stimulate the immune system. So I've mentioned those biologics and small molecules, which are trying to suppress certain parts of the immune system, but people are looking at medications that might upregulate the good parts of your immune system. So that's all being studied in clinical trials now. And just a few words, as Jamie mentioned, I do have a special interest in trying to help people through the pre-conception, pregnancy, and postpartum time periods. So again, I think that's just important for you, or if you have family member or friends, to make sure that you are comfortable to talk to your GI about where you are in your family planning. Because active IBD can make it harder to get pregnant. Active IBD can reduce your fertility. And so it's really important to try to get that under control. And then, oops, an active IBD before pregnancy increases the risk of flaring an active disease in pregnancy. And that is associated with a lot of complications, including pregnancy loss, early deliveries, smaller babies, and preeclampsia, which is like a blood pressure and placenta disorder. So that's why we're very, strongly aggressive to try to control the disease before and during the pregnancy. This is just to illustrate that we do recommend people stay on their medications to control the disease. But it's important to know where people are, because there are certain medications that should not be given because of concerns of risk, like of teratogenicity, before and during pregnancy. So that's why, are you actively trying to conceive? In which case, we try to get your disease in remission, but not use the JAK inhibitor or the S1P modulators. If you're not going to be trying for several years, then, we could use those, get you into remission, and then may need to switch to something else later. If you are pregnant or breastfeeding, the biologics can be used at their maintenance dose. When we didn't have enough evidence out there for continuing, like for the safety, we would actually stop and hold, and then people would flare. They would need to take steroids, and steroids had complications as well in pregnancy. So a lot of the large cohorts, like in the States and Europe, and then also we are trying to also build our own experience and evidence, all shows that the active disease and complications and steroid complications are probably more risk than staying on these medications, with the exception of JAK inhibitors and the S1P modulators, which we do not recommend taking or staying on. And then the final few minutes on the team approach. So you as a patient are the middle of it. Like all of everything that the clinicians are doing is to help the patient. So it's really important, though, that they all know who each other are. Because unfortunately, especially in Ontario, our healthcare system, like the electronic records and stuff, don't talk to each other easily. And so as like, for example, if I'm your GI, I might not know that you have a new family doctor. I might not know that you were diagnosed with, I don't know, like the arthritis and seeing a rheumatologist, unless you tell us, and we can connect everybody that's in your care team together. And it's really important as well. For example, we often get asked for a second opinion, or we might take over your care from another gastroenterologist, or maybe you move. So the more you know about your disease history, the better it is. So when were you diagnosed? Who diagnosed you? If you can remember, like the city, the province, country, hospital, clinic, like we can try to get those records. Who has been in your circle of care along the way? The gastroenterologist, surgeon, internist, family doctor. Do you remember what medications you've been on and whether they worked or not, or did you have side effects? And then what other comorbidities have you had in your history? And then what's happening now? Like who is in your circle of care like currently? What medications are you on, and you're having side effects, or do you feel that it works? What other comorbidities do you have? Who's helping you? What medications you're on? And then most importantly, where are you in your life, so that your gastroenterologists and clinicians can help you adjust wherever you are. If you're moving for school or moving for work, family planning, like we'll help you through that. Okay, so I hope, thank you for listening. That was, I tried to cover a lot, but I hope it helps that you kind of understand maybe a little bit where your GI is coming from, but also the importance of, we want to hear from you, like as the patient, like what's happening in your life. What are you worried about? What are you concerned about? Do you feel like the medications are helping you or not? And all of that. And then I think we'll have time for questions if people have any.
I think there was a question from about biosimilars in the chat.
Oh, yes. Yeah, so biosimilars, we can't call them generics. So you're probably familiar with generic meds. So that's like Tylenol and the acetaminophen. So another company makes their version of Tylenol. And the reason we can't call biosimilars generics is because they are biological molecules, like they're cultured out of cells, and They're not exactly the same way. But in order for any biosimilar to get approval, the company, like the researchers and scientists, have to show that it's the same structure. So, like for example, the anti-TNFs and infliximab, a biosimilar to infliximab, they have to show that it's the same overall structure. It works the same way, like the levels and antibody levels are all the same. And they all have to go through clinical trials initially. Now, the difference between the biologic originator getting on the clinical trials and approval for Crohn's and ulcerative colitis versus a biosimilar is the original ones had to have like the specific clinical trials where people are randomized to placebo versus the drug. Whereas biosimilar, they only have to get approval for one indication. And the most common indication is the arthritis and psoriasis, because they were the ones who were approved first for most of these biologics. And then once they get approved for that and show that the similarity is usually like 10 or 15% plus or minus in efficacy and safety, it has to be then an indication for IBD. If that makes sense. So at the beginning, like a couple of years ago, many of us, even gastroenterologists, because there wasn't a lot of data specifically for IBD, we were very concerned, what happens if someone switches to biosimilar? Are they going to flare? Are they going to run into troubles or back and forth? However, now, like that we're in 2025, there are published data on IBD patient experiences. And so in Canada, Ontario was one of the last provinces to go to biosimilar. Out west had to go first, Alberta and BC. And we're also one of the last countries in the world to go. So Europe has actually already gone biosimilars like 10 years ago is what they told us. So we're very comfortable now, like switching people from an originator to a biosimilar because of the insurance issues. We still dose it the same way. We monitor the same way with same drug levels, like everything the same. I hope that answers that. And
there's two more in the chat box. One, can you speak briefly about the treatment evidence of microscopic colitis and whether there are any active clinical research programs?
Oh gosh, yeah. Yeah, I'm not aware of any specific clinical trials. There probably is some. But yeah, the limited evidence for microscopic colitis comes from off-label use and stuff. So there is some evidence out there for, like Entyvio has some evidence out there. The Remicade has some evidence to work for microscopic colitis. And then before you go to biologics dose, your GI might recommend the 5-aminosalicylates or the sulfasalazine, because there was some evidence for that too. But I'm not aware of any specific clinical trial yet. There probably are some, there will be some for that.
Sheldon has asked about ODB coverage for Stelara for psoriasis, but not for Crohn's. I mean, is psoriasis greater need than for the med?
So that's weird. I don't know the answer to that, but you're right. In Ontario, Stelara was never approved or covered by the public insurance, so patients would get it off through the BioAdvance. At least my patients, like when I order Stelara, they would get it through the BioAdvance Compassionate. However, now that there are biosimilars out there, there's 3 or 4 ustekinumab ones now. They are approved through the LU code for access for IBD. So it's a little easier, I guess, to get access for that mechanism of action. If you have to increase your Stelara, yeah, exactly. So if you need to increase, so Stelara dosing, there's only one dose, 90 milligrams, but the frequency, yes, you can go to every 4 weeks, or some cases every 6 weeks. So I would talk to your GI and see like if you are in the BioAdvance program or whatnot to get access to that.
Another one there to come up.
Yeah, I think I see a question here, Megan. Could you, about how a scope can be clean, but an MRI shows disease and structure. So that's so if you remember when I was talking about Crohn's disease and how Crohn's is transmural, so it can affect different layers of the bowel. So that's what I mean. So like when we do your scope and we can only see the inside lining, so the mucosa, and it can look good and healthy. Whereas the MRIs and the imaging, they can look at all layers. And so they can see beyond that mucosa, and they can see that there's inflammation or narrowing like above it. And the stricture meaning like a narrowing, for example, our scopes are like the size of my finger, like the size of my finger, as you can see. So, you know, when we do our scopes, we put air and water in, and we can sometimes see if there's a narrowing because your bowel won't expand like we would expect. But sometimes that narrowing isn't necessarily appreciable, like through us just putting gas and air and water in your bowel. Like they actually need to see it through when they make you drink stuff, and then on the imaging test, they can see like the narrowings and the dilation above it, because it's three-dimensional, whereas we can just see the lining, the inside lining. But I would highly encourage you to ask your GI to show you. I mean, it's not always feasible, but I know sometimes when people come to Mount Sinai Clinic and I can pull up the power chart, I can show the images. Sometimes I even pull up like the CT scan and will show like my patient, like, hey, this is that area that we're talking about. It might help. You can ask your GI if they have access to show you some of the images.
Like being in the dental office, they can show exactly what you're doing with the CT scan.
Yeah.
Jamie Baker, since I'm kind of doing this, do you think it would be appropriate for you to speak a little bit about your experience with Dr. Huang and how she handled it or not? I'm just throwing that out. I don't know.
Absolutely. If anyone wants to hear my story, yeah, I had both my pregnancies. I did have a flare up afterwards. I did have a different GI before coming to Dr. Huang with my first pregnancy. So afterwards, my first baby I had during the COVID lockdown, first week of lockdown. So yeah, I'm sure you can imagine that was not the experience we were hoping for. But I had a major flare after that pregnancy, and it was very hard to get into testing because there was minimal tests available. The medical, like all the hospitals were running pretty much on the minimal staff they could. So getting into any testing or doctors was pretty challenging at the time. So I did get switched over to Dr. Huang at the time, and she helped me navigate my first flare postpartum. And that did involve going on Stelara. And then I did need surgery to have a resection. I had abscess, fistula, everything kind of escalated over that course of the year while we were in lockdown. But once I did have the surgery, I was pretty good. And we did eventually have a second kid. And after the second one, I did have a flare as well, but it was different. It actually affected my joints instead of my intestines. So Dr. Huang did try to help me. We tried to figure out why my CRP levels were through the roof, and she had told me to go to the ER, and turns out that I guess it just the Crohn's kind of attacked my joints that time instead of my intestines. So they put me on prednisone, and I was very lucky that the prednisone actually stopped it in its tracks, and it didn't actually return afterwards, because they were talking about going on a second biologic to help with arthritis, which I was thinking was a bit crazy to have two different ones. But yeah, since then I've just been just doing the maintenance drugs with Stelara and being monitored by Dr. Huang, and everything's been great since. So I'm very lucky.
I have a question about I'm on Stelara, and I've been on many of the medications over the years since I've had Crohn's for a very long time, that you mentioned, but there are a lot of new medications that you listed. And I'm wondering, for instance, with Stelara, there were about 5 or 6 other medications that seem to be different. Are they newer? Do they do different things? Would it be helpful to have a list of them and what each one is for?
Yeah, so the ones that maybe the slide that I had where I listed a few next to Stelara, those are the biosimilars that came out now. So those would be the same. So there are new biosimilars, which are basically the other companies made their version of Stelara. So it wouldn't make sense unless you had to switch for coverage issues, like to go to those ones. If your insurance still covers Stelara, then just stay on Stelara. The other medications I listed, like the other classes, so like the anti-IL-23 agents, you know, the JAK inhibitors, S1P, those are available as well now. But what I usually tell my patients, like if the one you're on is working, and you don't have side effects, why change it, right? Like, because we can't promise you that the next one is going to work. Even the clinical trials are not 100%. When you look at the clinical trials that get these drugs approved, I mean, the best that we've seen is probably like 70 or 80%. People would respond. It's not 100%. So if the current medication is working and you're not having any side effects, then you stay on it, right, for as long as possible. But always have the discussion with your GI. So if you feel like it's not working, or if they've done a scope or imaging and they're like, oh, there's some inflammation coming back, like, can we get it better for you? Then you have to have that discussion, right? Is it worth like changing and potentially getting better, but understanding that it might not work? If you're unfortunate and you're in that 20%, for example, where it doesn't work, then do you just go back to the one that you're on?
But it would be helpful to have a list of the medication like Stelara and the biosimilars, so that we have a sense of if one is sort of working but not totally working, what would we switch to?
And actually, when I looked at the Crohn's Colitis Canada website, because I gave the link to a patient today, I wanted to make sure that they actually do have on their medication section, like all these different medications and the biosimilars, I think.
Oh, okay, I haven't seen that.
Yeah, it's on the biotherapies section of the Crohn's Colitis Canada website.
Okay, good. Thanks.
Anybody else have their hand raised up? I had a question just about Jamie, if you can say, was the SED rate up and the C-reactive protein up at that time? Do you remember?
Was this for both of mine? Are you just talking about like after each pregnancy, you mean?
Yeah, and the sedimentation rate when you had inflammation, was it way up there? Kind of like we see with the polymyalgia rheumatica.
I don't know what the comparison is. I do know that they were obviously elevated. Like with my joints, like I think my CRP levels were at 60, and I know that they're supposed to be under 5. So it definitely showed that there was something going on.
And Dr. Huang, the SED rate, was it way up? Do you remember? Or?
I don't remember, because I usually don't check ESR. Like, I know rheumatologists do. We actually had you see a rheumatologist as well, like, to make sure what's going on. But...
Yeah, I still being followed.
Thank you. Anybody else? I don't have the whole list of people across who've got their hands up.
I see a comment. Sheldon was asking, is it 2 months Stelara doses of night? Yeah, actually, so what I should mention is the risk of antibody development is the highest in the anti-TNF. So Stelara and the vedolizumab, their studies showed less than 3 to 5% of people actually make antibodies. And so yes, like the every 8 weeks standard dosing doesn't, like, less than 3 to 5% of people will make antibodies at that level. Psoriasis patients actually take it every 12 weeks, but for IBD it seems to need more frequent. And then now even the newer ones, the risankizumab and mirikizumab, there are no drug levels that we can check, because when they did the studies, like, people just didn't make antibodies. And part of that is probably the way that these biologics are made. So the older one, the original Remicade, and still the current, like, infliximab Remicade ones, they are chimeric, so they're part like mouse protein, part human protein. But then all the newer ones are very like the human cell growth and human proteins, and that's probably why people don't make antibodies as much, hardly ever.
So Brenda, I hope I'm doing a decent job here trying to navigate back and forth here.
You are absolutely doing a great job.
How would you like this to continue? I mean, Dr. Huang, thank God for smart people who care, because it's just been an amazing hour. We thank you so much.
Yeah.
How did you want it to continue?
So if people want to stay on and chat, we're welcome to continue on. This is the problem with doing virtual as opposed to being in the auditorium. But if people have questions or just want to share or want to connect with someone, you're happy to stay on. So it's your meeting, guys, whatever you want to do. But Vivian, we're very grateful for you.
Thank you. I mean, if anyone has any more questions, otherwise, you know how to find me, Brenda. So I'll leave you guys to your meeting, and Brenda can connect me if you have more questions or whatnot. Thank you.
Okay. Thank you, Viv.
Bye.
All right, folks. So our next meeting is the end of March, when we're going to have Dr. Tay Hart, a clinical psychologist, kind of talk about coping and life and all the rest of it. But I'm not sure exactly what her talk's going to be yet because she's on sabbatical. But if people have questions or want to talk now, unmute yourself and talk away.